identify and review some of the most common birth defects. And there are a bunch of these, as you can imagine. But the ones that we probably should be the most familiar with, not necessarily from a treatment standpoint, but just having an idea of what we're up against when we respond, and the parents or the caregivers are trying to tell us what is going on with their particular loved one. So for each birth defect discussed, we'll look at the following information: pathophysiology of the defect, so what causes it, the frequency, so is this something that, it's a once in a career encounter, or is this something that they send these patients home pretty routinely with? Typical presentation, the treatment, and that's pre-hospital and hospital. We're not going to go in depth on the hospital treatment. It's just more, is this a medication thing or is it a surgical intervention? Expected outcomes from it, and then other considerations for EMS providers. What you guys will notice though, as we're going through them, most of them are going to kind of say the same thing. To be 100% honest with you, we'll say it depends on the severity of the defect as to what signs and symptoms are going to have and what the fixation is going to end up being. So just kind of bear with me as we go through that, because, and it makes sense, if this is something that it's a small hole in the heart and it may heal on its own, well, then there really doesn't need to be an intervention. But if it's a larger opening, then they're going to have a surgical intervention, which clearly is going to be a more in-depth process, and they have to be at a specialized center, et cetera. All right, so congenital heart defects, they're kind of broken down and classified as CHDs, and that's what the reference will be here basically for the remainder of this lecture. So congenital heart defects are the most common of all of the birth defects, and CHDs are present at birth and affect the structure and the function of the baby's heart. So all we're talking about in this portion that we're diving into right now is defects that are surrounding the heart itself. It's estimated that approximately 2 million Americans are living with a congenital heart defect. And one thing that is important to mention here is these don't necessarily go away. They may be fixed or repaired, but the patient is still considered to have a congenital heart defect, and they're probably going to end up continuing to follow a pediatrician. So it would not be uncommon in these situations for an adult patient, somebody over the age of 18, even into their 20s or 30s, to still be seen at Cincinnati Children's Hospital. And you guys may have been asked to transport adult patients there for these conditions. Your congenital heart defects can vary from mild to severe, as I was kind of opening with. So a mild form may be that small hole in the heart, a ventricular septal defect or a VSD, or it can be something like hypoplastic left heart syndrome, which we're going to discuss. You guys have probably heard that term before, but may not know exactly what it is. So of the babies born with heart defect, about 25% are critical congenital heart defects. So 1 in 4 are going to end up having some critical abnormalities that require surgical interventions. So signs and symptoms. This will depend on the type and the severity of the congenital defect that you're actually up against. So if it is, that small ventricular septal defect, that's just a hole in the septal wall that separates the right ventricle from the left ventricle. And you can understand what that would cause. So in the right ventricle, under normal conditions, we have deoxygenated blood because it's trying to get over into the pulmonary network to have gas exchange. That left ventricle, on the other hand, is oxygenated blood, and that blood is getting ready to be pumped out through the aorta into systemic circulation. Well, if you put a hole in the middle of that septum, then clearly we're going to have venous and arterial blood that starts to mix, and you're going to end up getting signs and symptoms that go along with that. So if it's a very small hole, then the symptoms may not be all that big of a deal. If it is a larger hole and causing that VSD, then you can see that you got the arterial blood on the wrong side and the venous blood on the wrong side, and clearly that is not going to work out real well for your patient. So some of the signs and symptoms that are going to be pretty much standard and commonly found across all of these congenital heart defects are going to be blue nails or lips. So as far as capillary refill or the circumoral cyanosis, the bluing color or discoloration around the oral cavity. Very, very common finding in all of these CHDs. They'll have tachypnea, so they have an increased respiratory effort, and that's a compensatory mechanism. And then excessive tiredness. So the parent, even if this is unrecognized, this is one of the big clinical findings that helps the provider say, okay, well, I need to get additional testing to go along with this. So if they have that excessive tiredness or fatigue, and most of the time the parents will say that it seems to happen when they are feeding. So they have this infant, they're trying to feed them, and the baby wants to continue to fall asleep. Those are big clues and will probably end up leading them to further diagnostic testing. So how are they diagnosed? It really depends on the condition that they're looking for and what the diagnosis is that they're looking for. So it can be from an ultrasound that is done during pregnancy to findings that they just learn about once the baby is in extrauterine life or at birth. So some of these aren't realized until later in life. This would be a situation where an individual may have a dilated cardiomyopathy. So these things can be picked up on by some simple tests, but they aren't necessarily always done. And where you will see this, and it's separate from the commodio cordis, but these are your athletes, your people that are on a basketball court, have no previous medical condition, and then go into cardiac arrest, or potentially an NFL player. I know that there was one of those not too long ago, college athletes that end up cardiac arresting, and then on post-exam, they figure out that they had a dilated cardiomyopathy. So that may be something that wasn't necessarily present at birth, but developed, or it can be something that was there from the beginning. So clinical findings would be a murmur. So that's an example of one of the clinical findings, and why when you go for your sports physical or your annual physical, the doc is going to end up putting a stethoscope over your heart to hear if they hear any type of murmur activity or anything that sounds suspicious that they need to send off for additional testing. And then really the gold standard is one of two things. The ultrasound during pregnancy can give a lot of information, but beyond that, it's probably going to end up going to an echocardiogram. And up in the top right-hand corner is an example of an echo and what that echo would look like. So how are they treated? So, and we're just talking general treatment at this point, not necessarily specific to the particular issue. So it depends on the severity and the type of defect, which that makes sense. So surgery is going to be the ultimate repair, but some of these do not necessarily require surgery. We're just going to keep an eye on them, like we do with a lot of things, to see if there is any type of progression. And if it progresses, then we need to go to the next step. If it doesn't progress, or it actually starts to fix itself, then we don't have to worry about it. Cardiac catheterization can be used for the following. So, and they don't necessarily always go into the femoral at this point. They're doing some of these up through the radial artery. So they're going to probably cannulate the radial artery and then get into the heart that way. But they can assess the severity of the defect. They can get images. So they'll actually take pictures of the defect using cardiac catheterization. They can measure the size and the location of the defect, because that will become important on whether or not it will heal on its own or they're going to have to fix it. And then there is the ability to make some small repairs even during the cardiac catheterization procedure. So the technology there has come a very long way. So our cause is known. It really depends. And it depends, again, on what CHD you're talking about specifically. So gene or chromosomal mutations are clearly something that should be looked at. Environmental factors, mother's diet, the maternal health conditions prior to the pregnancy. So did they have pre-existing diabetes, type 1 and or type 2 diabetes prior to getting pregnant? And did they have obesity that also went with that? If so, then it increases the risk for the baby to have a congenital heart defect while in utero. Any medications that mom is on during pregnancy, and then smoking during pregnancy. And these are all just common sense things that we've heard many times before. So long-term effects, things have gotten better here. So it used to be that if a baby was born and had a congenital heart defect, It was pretty much a grim outcome because the technology was not there to be able to fix it. And that is no longer the case. We're very fortunate, as I've mentioned, that we have some smart people in Northern Kentucky in particular. We have people that are close by that have the ability to fix and figure some of these conditions out. And that is allowing the patients to live longer in life. And most of them are getting into adulthood. Congenital heart defect patients, most of them are going to end up being able to lead an independent life with minimal complications. So you may end up responding to a house where the patient is there and they tell you, this is what's going on and this is my condition. And there isn't really that caregiver there that we would expect with some of the other long-term medical issues that we respond to with regards to the pediatric patient. So I mentioned this a few minutes ago, even with a repair to a congenital defect, the patient is never considered to be cured of that particular defect. So they may have surgery, but if they have an ASD, which is an atrial septal deform, or if they have that ventricular septal deform or defect, then what you're going to end up finding is that patient will always have that as part of their medical record because it can open back up. And the chances of that happening are slim to none, but they will end up going back in and they'll follow that same physician or that same practice for a long period of time to make sure that things are trending in the correct direction. So if they have chronic health problems that can go along with that, what you guys are probably going to find in the field is arrhythmias. And some of these we're going to manage based on your PALS or your ACLS guidelines, and others you may not. Infectious endocarditis, that's just an infection of the heart muscle, and that's IV heavy-duty antibiotics in the hospital setting. So nothing that we need to manage unless you're doing a transport for some reason. And then cardiomyopathies, and that's just weakness of the heart muscle due to an enlarged heart. So as the heart stretches out, the myocytes, the portion of the heart that actually causes that contraction, they actually start to weaken in some extent, or to some extent, and that disallows the heart muscle to expand and contract the way that it should under normal condition. So we're looking at the specific congenital heart defects that I think are important and that we need to talk about are the ones that are listed here. I'm not going to read them all off to you because we're going to look at each one of these individually. All right, so an atrial septal defect or a deformation is basically when you have a hole in between the septal wall that separates the right atria from the left atria. And as I mentioned before, you have ventricular septal defects or VSDs as well. Same concept here goes. Oxygenated and deoxygenated blood start to coexist, and that is obviously not going to be a good thing for the patient. So I want you to think about it. Under normal situations, we all had an ASD, an atrial septal defect in utero. But when we're born, hopefully because of some things that are occurring here, such as changes in pressure, stimulation of the baby, a change in pH, and an elevation in your CO2 or carbon dioxide, it causes that hole to close. In ours, if it closed, like I think it did for most of us, then we no longer are said to have an the atrial septal defect. What ends up happening though is if that hole is large, or if these changes in pressure and pH and CO2 don't cause that hole to close off, then that atrial septal defect continues to exist, and you're going to end up getting the oxygenated blood from the left side of the heart going to the right, and the deoxygenated blood going from the right side of the heart to the left. And that is going to end up either doing one of two things. If the patient is stable, they may end up watching that and seeing if that hole will close off in due time. If it will not, then it's going to end up requiring a surgical intervention. So here's basically what it is. You can see in the diagram here, a hole in between the right and left atria. That is your atrial septal defect. And over time, what's going to end up happening is if this does not get fixed, there is going to be an increased pressure that backs up into the pulmonary network, and it will lead to pulmonary hypertension and then ultimately cor pulmonale. And cor pulmonale, to refresh your memory, is that right-sided heart failure caused by high pressures in the lung. So if we can't get this surgically corrected or it doesn't close on its own, the backwards pressure is going to end up in that pulmonary vein into the lung and then ultimately into the pulmonary artery. And that's where your pulmonary hypertension is going to start to come in. How prevalent is it? About 1 in 1,859 births. So it's something that happens pretty routinely, and that was back in 2019. I'll only say this once. All of these numbers are going to be based in the United States. And all of them are pretty recent data. I don't know that all of them off the top of my head are going to be 2019, but they're all relatively recent past as far as the numbers that I pulled. Atrial septal defects are of an unknown etiology, so we don't know exactly what causes these. It may not necessarily be anything that mom did wrong or the environmental factors that go along with that. How are they diagnosed? So a lot of them are diagnosed during pregnancy, but they can be diagnosed after birth or in adulthood. And probably what they're going to end up finding is that these patients have frequent lung infections. So if this is an adult patient, they keep going in because they have an infection in their lungs and they can't figure out what the problem is. So that leads to ultimate further testing and an echocardiogram, and they go, oh my gosh, you actually have an ASD that we need to have surgically repaired. The patient will be short of breath. They're going to hear a heart murmur, or they should be able to hear a heart murmur, tiredness when feeding, and then arrhythmias, the things that we've already kind of mentioned. And it depends on how long in life this is before it is actually diagnosed as to what conditions you're going to find. That frequent lung infection, you know, clearly if this is in a baby that is just born, you know, they're going to be looking at other things. But as this is a child that's a little bit older or even into adulthood, they're going to ultimately end up going back and looking at some of the diagnostic testing that maybe they should have done a long time ago. So treatments, it really depends on the size and the location of the defect. So there are two different ones that they can go in there, and essentially these are two different fixations that they would do surgically, but you can see that they kind of have the same appearance to them. So what they will do is they'll actually go in through that radial artery or maybe the femoral artery. They go and it allows it to flow into that right atria. And then once it's in the right atria, they'll feed it into that septal opening. And then they basically put this device in there and that occludes that hole. And then it's just a matter of sending them home and making sure that they have appropriate follow-up care so that there's not any type of leak around that. There's something called d-transposition of the great arteries. So what that is exactly as it sounds. So all of the great vessels are basically flipped. So reversal of two arteries lead to low blood oxygen levels, the pulmonary artery and the aorta. So those two arteries are not in the right spot. The aorta ends up becoming where the pulmonary artery should be, and the pulmonary artery ends up becoming where the aorta should be. So it ends up causing some problems for your patient. Many children that have this transposition of great vessels will also have other congenital anomalies that go along with that, like the VSD or the ASD, and then patent ductus arteriosus. And the ductus arteriosus, if you remember back to EMT or paramedic school, that is basically what we're talking about, where the hole doesn't close off and leads to that atrial septal defect. So what happens here? And under normal conditions, remember that the right ventricle pumps blood into the pulmonary artery and then into the lungs, okay? But if those vessels are reversed, the right ventricle is attached directly to the aorta, and deoxygenated blood is sent from the right ventricle into the aorta and then out through the body. So it never makes it all the way to the lungs. And that is what happens in the transposition of great vessels. So these kids are going to be very sick because they're not getting oxygenated blood, because the blood flow isn't going to the lungs to pick up the oxygen that it needs. Here's what it looks like. So on this diagram here, we have our right ventricle. but you can see instead of it going through that pulmonic valve into the pulmonary artery, it actually is attached directly to the aorta in your aortic valve. So when that valve opens up, now you have deoxygenated blood that is actually being sent out to systemic circulation. And what they're going to have is severe hypoxia. So how often does this occur? 1 in 3,413 babies born will be affected by the transposition of great vessels. Most of these are related to unknown causes. However, maternal genetics and environmental factors they think may be a cause, but they haven't actually put a thumb on a specific reason that some of these d-TGAs are actually occurring. So how do they diagnose and test for this? Well, diagnosis during pregnancy is going to be from an ultrasound or a fetal echocardiogram, and it's just more of a detailed echo. And then after delivery, it's going to be the signs and symptoms, and they're going to be very, very evident. These patients are going to have difficulty breathing, a weak pulse, a bounding heart, and that is because of those vessels not going through the normal mechanism. And then blue or ashen skin because we're circulating around deoxygenated blood. So newborn pulse oximetry screening, if you have the ability to put these kids on pulse oximetry after delivery, you may actually start to see that you can find some of these congenital heart defects in the pre-hospital setting. So it should be after warming, drying, stimulation, you know, those types of things that these babies actually have fairly normal pulse oximetry. It may take a little bit of time because of something called acrocyanosis, and that can develop after delivery, and that's just basically the bluish skin appearance to the extremities, and that can last for a couple of days after a delivery. So it may be difficult to get a good reading, but if you can get a good reading, if their extremities are warm and you think there's appropriate blood flow there, then newborn pulse oximetry may be a big indicator that there's something wrong. Treatment here is an atrial switch operation. So this is going to end up being a surgical emergency. They do this within the first month of life for obvious reasons. They've got to try to fix this so that the baby can have somewhat normal function. And it ends up restoring a normal blood flow throughout the body. The pulmonary artery and the aorta reversed are put back to normal. And then they end up putting them on medications to try to control everything. So they will be on medications to control their blood pressure. They don't want high pressure. So it's not to raise their pressure, it's actually to keep everything in check. They can get some tachycardia and bradycardia from the medication management. Those are basically side effects that they'll have to watch, and then occasionally they'll have to put in a pacemaker, and that's what you're seeing here is a pacemaker and the pacemaker wires in an infant's chest. Another one is called hypoplastic left heart syndrome, and you guys have probably heard this term before, but during fetal development, the left side of the heart does not form, and that's what's going on in hypoplastic left heart, and this is a critical congenital heart defect. So if you think about the entire left side of the heart and what should be there, just think that none of it is formed and none of it is functioning correctly. So the left ventricle is underdeveloped, so it's too small. The mitral valve, which sits between that left atria and the left ventricle, it is not going to be there, or it's too small to allow for proper blood flow. The aortic valve, which is in between that left ventricle and the aorta, is not formed or too small. And then the ascending aorta, which is how blood is getting ejected out from that left ventricle, is not going to be there or is going to be too small. So things are going to start to back up. Hypoplastic left heart, critical congenital defect. And what you can see here on the diagram is basically the right side. If we're looking at this purplish area, that right side looks pretty normal, right? We have our right atria, we have our tricuspid valve, and then we have down into the right ventricle. And from the right ventricle, it should go through the pulmonary artery and then to the left. In this particular diagram here, you can see they have that left atria, but the left atria is probably undersized. That mitral valve is very tiny. Look at the size of the left ventricle. LV, that left ventricle, very, very small. And the rest of it is just made up of muscle mass. So that's not going to necessarily do us any good, and they're going to have surgical repair. This too isn't nearly as common, one in about 3,800 births, and it's similar to the other ones that we've already talked about as far as etiology. We don't really know exactly where it's coming from, but it could be a chromosomal issue with mom. Smoking cessation, not drinking alcohol, and taking multivitamins with folic acid during pregnancy has shown effectiveness in reducing congenital heart defects. So it is important for mom to be on a multivitamin and also to have good prenatal care during her pregnancy. So that would be a question that I think would be beneficial for you to ask. Diagnosis and testing, same thing as we've talked about, ultrasound and echocardiogram. You can try the newborn pulse oximetry once again, and then it's going to be signs and symptoms of respiratory distress. So trouble breathing, a weak pulse, and then blue skin or that cyanosis that we've mentioned. So all of these you're going to see basically same concept as far as what they're going to look like. Treatment, they're normally going to end up having this done in the first couple of weeks of life because they're not going to be able to sustain life for a very long period of time. So, and this is an ongoing situation that they're going to have multiple surgeries to correct this issue. So there's something called the Norwood procedure that they'll get in the first 2 weeks of life, and the aorta is basically constructed and attached to the right ventricle. So that's a good thing. That's where it should be attached to. Then there is a bidirectional Glenn shunt procedure, and that's performed at about 4 to 6 months of age, and that connects the pulmonary artery to the superior vena cava. So the blood is coming into that right side of the heart through the superior vena cava, but instead of going through the right side of the heart, it is going directly over into the pulmonary artery. So that puts a reduction in workload into that right ventricle. And then the third one is the Fontan procedure, and that's performed at 18 months to about 3 years of age. And this is where the pulmonary artery and the inferior vena cava are connected together. So remember where the pulmonary artery lies, that inferior vena cava bypasses the right side of the heart, kind of like we talked about up top with the bidirectional Glenn shunt. It goes directly into the pulmonary artery. So it is bypassing the right side of the patient's heart. Another one is Tetralogy of Fallot, and they will actually just say TET. And that is made up of 4 different defects. So the other ones that we've talked about, such as your hypoplastic left heart syndrome, it can be a bunch of different issues, but it's all affecting like one side of the heart, and it is one condition. When we're talking about Tetralogy of Fallot, it is 4 different defects, and the 4 defects are a ventricular septal defect, so that's that opening in the septum, pulmonary stenosis, so an opening in the pulmonary network that is reduced. That is what a stenosis is, or a stenotic valve, an overriding aorta, and we're going to look at that, and then hypertrophy of the right ventricle. So that right ventricle actually becomes enlarged. And that is what it looks like on a transvaginal scan at 11 weeks of gestation. So when they do these scans, they can pick up on these. Again, I don't have the ability to read that. I don't have that knowledge, but somebody that reads your echoes and your ultrasounds would be able to look and see that the patient is suffering from tetralogy. So here's the ventricular septal defect, kind of what we talked about already. The septum should form between the 2 ventricles, and it does not happen that way. So we have that oxygenated and deoxygenated blood mixing, as we've already talked about. Pulmonary stenosis, I told you it was just a narrowing of that valve there, and that's that pulmonic valve. So it is very narrow, and blood is not going to be able to get through from the right side to the pulmonary artery. So things start to back up, and that is going to end up leading to that right ventricular hypertrophy, because the pressure there is making that right ventricle get bigger. And that is the hypertrophy that we are referring to. The third part of the tetralogy is an overriding aorta. So what happens here is the aorta, it's an enlarged aorta, and it opens from both ventricles instead of just the left. So under normal conditions, normal blood flow through the heart, that left ventricle will send blood up through the aortic valve and into the aorta. when you have an overriding aorta in Tetralogy of Fallot, it does not happen that way. You get blood from the right and left ventricle that go directly into that pulmonary artery. Instead, it goes into the pulmonary artery instead of where it is actually supposed to be going. But the opening to the aorta comes from both directions, the right and the left. And then here, because of that backup, as I mentioned, you end up with that right ventricular hypertrophy. So if you look at the picture on the left, this is a normal heart. Look at the wall of the right ventricle. It's pretty thin. And if we compare that to the left ventricle in the normal heart, you can see that that left ventricular wall is a little bit thicker. And that makes sense because it's under a higher pressure system. Well, if we look at the patient in the other diagram, the heart with Tetralogy of Fallot, that right ventricle is much thicker, even so than the left. And that's because all of the pressure is being exerted into that right ventricle. So 1 in about 2,500 in the United States, it's thought to be associated with maternal diet and environmental factors. So again, good prenatal care and having mom do what is best during her pregnancy will reduce the risk of the baby having tetralogy. And then maternal medications may also have some role in that. I didn't go into putting the medications in there in particular because we're not going to be using them, first of all. And they're not really sure if that is even what the causative agent is. So diagnosis and testing, same thing, ultrasound and echo, newborn pulse oximetry, but a murmur is often heard in these situations. And what mom or dad will end up telling the provider is that when they are doing feeding, so the baby is eating, they all of a sudden turn blue. And that is very characteristic of a patient that they will end up finding Tetralogy of Fallot with. So what do they do for it? They're going to end up having a surgical patient on their hands. So they have to do surgery. They're going to widen the pulmonary valve to get more of that stenosis away and allow blood flow into the pulmonary artery. And then they patch the ventricular septal defect. So they end up going in there kind of like they did with the ASD, and they patch the hole in between the two ventricles. So patients with Tetralogy of Fallot, this used to be kind of a death sentence back in the day, but with proper treatment now, most of these infants will live an active, healthy life, but additional surgeries may be needed as they progress throughout childhood or into adulthood. So, you know, it's kind of a scary thing, and I'm sure, and I was fortunate that we did not have to go through any of this, but I'm sure it is very, very concerning and worrisome if, you know, you're expecting or have had a child that has some of these conditions. But the good news is now the technology really allows for a lot of them to be managed and treated. And for the most part, the kids are going to end up living a pretty normal life because of that. Ventricular septal defect, we've talked about it enough. I'm not going to rehash it. It's just another one that that is commonly found, but we've already talked about it with Tetralogy of Fallot and also drawn parallels with the ASD. So I'm not going to rehash that here. Approximately 16,800 babies born annually. 42 of 10,000 babies born have a VSD. So you can see there's not a ton, all right? 42 in 10,000, and this equates to 1 in 240 babies. So it is more prevalent than what some of the other conditions are, where we were talking like 1 in 2,800 and 1 in 3,200. But it's not something that there are a ton of babies that are born that have this ventricular septal defect. There are different types of VSDs. As far as covering all of them, I don't know that it's important to cover all of that. It's just more important for you guys when you respond. If they say the baby has a history of a ventricular septal defect, I really just wanted you to understand what it is and why that could be problematic. Diagnosis and testing, really, it's going to be after the baby is born. And you get, again, see they have poor weight gain, and that's because they keep falling asleep when they're eating. So sleepiness when feeding, very characteristic of this, and as such, the patient is not going to be able to take on much weight. Under normal conditions in the first week of life after birth, the infant should lose or can lose up to about 10% of their body weight. But then after that, they should really start packing on some weight. And if they don't do that, then again, it should be an indicator that we need to look at a little bit more closely at this patient. Treatment options here, if the VSDs are small, it will fix on its own and they may not have to do anything. If it is a larger VSD, then surgery may be required. All right, and then kind of getting out of that, there's a couple other things that I want you to be aware of for response purposes that are not necessarily considered CHD, so congenital heart defects, and that is cleft lip and cleft palate. So during pregnancy, when the baby is in utero, the lip forms between the 4th and 7th week of gestation. And the way that that actually happens in utero is the tissue actually comes from the side and it actually starts to form in the middle. So what happens when you have a patient that has a cleft lip, that tissue does not completely join before the birth occurs. So the tissue is actually separated, and now you end up having a patient that has a cleft lip. In a cleft palate, it's the same thing. The tissue in the oral cavity actually starts to come from the lateral aspects, and it comes together and it forms a complete fusion of tissue around the 6th to 9th week of gestation. And similar to that cleft lip, if the baby is born and that joining has not occurred, then the baby ends up having this cleft palate. And occasionally both the front and back palate are open. So we know we have our soft palate and our hard palate. It is occasionally found that both of those palates are not necessarily completely joined at the time of birth. How would you know this? And you guys may have, I went to school with somebody that actually had a cleft lip and cleft palate as well. So they will have difficulty speaking. And that is one of the biggest ways that you're going to be able to tell that the patient had it, in addition to probably scarring from the surgical intervention that they ended up having. But these patients are also going to be at an increased risk of ear infection. Remember, this is all connected. So if things aren't formed completely, it allows bacteria to get into the inner ear, and now they're going to have more ear infections than what the normal population would. So looking at these, the cleft lip on the left, and then the cleft palate on the right. So that tissue should have formed from both sides, and that's why the lateral aspects look normal, right? Everything looks normal as far as the lateral aspect, but it didn't necessarily come together and fuse completely before birth. So this baby has a cleft lip. And then on the right-hand side, same thing. You can see the palate, top of the roof, or the roof of the mouth, and that tissue doesn't completely form, so they end up with a hole up in the upper portion of the roof of their mouth. So that's what the cleft palate is. Just be aware of what it is. So 1 in 1,600 for the cleft lip, about 1 in 1,700 for a cleft palate, and about 1 in 2,800 have both. And certain medications, and they have actually attributed some of these to mom having a baby with a cleft lip and a cleft palate, are your epilepsy medication. So if mom is on topiramate or valproic acid, it puts her at an increased risk of having a baby born with a cleft lip or a cleft palate. So these may be things that if you're getting ready to deliver, ask mom if she's ever had any type of seizure history. And if she says no, you probably don't need to worry about it. But if she says yes, then depending on what medication she is on, the baby may end up in fact being born with this condition. So diagnosis and treatment, basically it's going to be diagnosed during pregnancy, and they find that with routine ultrasound. And then basically they're going to end up going in there and surgically repairing that. And that's for a couple of different reasons, not only to close it and I'll give the child the ability to talk appropriately, but also from a self-esteem aspect. You can imagine if you're a school-age child and you have this and it looks different than your friends, then you're probably going to be at risk for having some issues as far as self-esteem. Diaphragmatic hernia is another one, which is an opening in the diaphragm that allows basically the bowel contents in the diaphragm to not separate the way that they should. So the organs, the intestines, the stomach, and the liver can end up going through that hernia of the diaphragm, and now you end up getting bowel up into the chest. And that's actually one of the clinical findings is bowel sounds where you should be hearing lung sounds. You actually start to hear bowel sounds there. So the intestine, stomach, and liver do not allow for normal lung growth. So this is going to end up causing the baby to have problems as far as breathing, because all of that tissue from the abdominal content is up into the lung, and it doesn't allow the lung the ability to grow and expand the way that it would normally want to do that. So on the left side, you can see the normal child. You can see that we have our abdominal wall, and then you have the liver. And then just above the liver, you can see that you have the diaphragm. What ends up happening in your baby that has diaphragmatic hernia is there is a hole in that diaphragm, and it allows the contents of the belly or the abdominal wall to end up coming retrograde up through that hole. And that is what a hernia is, right? I mean, whether we're talking umbilical hernia or an inguinal hernia, diaphragmatic hernia, it's an opening in the tissue that is allowing things to go through that are not supposed to necessarily being in there. And that is an example of a diaphragmatic hernia. So one in about 3,600 births in the US, and approximately half of all babies born with a diaphragmatic hernia will have other birth defects with it. So something that affects their brain, their heart, or that goes along with intestinal issues that they may have. They believe that this is primarily a result of some sort of abnormality in the baby's genes. So not necessarily from mom, but from the baby themselves. Diagnosis. During pregnancy, the ultrasound may show a diaphragmatic hernia, but evaluation of the diaphragm and lungs during the ultrasound is when they actually find these. So it's not going to be on a typical just ultrasound. It's if they're specifically looking at the lungs and the diaphragm that they may actually see that they have this little opening there that should not be. So after delivery, cases are going to be identified because the baby has difficulty breathing. And then when they do a chest x-ray, the chest x-ray is going to show that the organs are misplaced, and that is going to end up leading the baby to a surgical intervention. So the child will need to be on a vent so that the lungs can heal and function normally as they continue through that healing process, but they're going to end up having to surgically repair that hernia and push the bowel content and all of the abdominal contents back down where they're supposed to be to get them out of the way. So nothing that we can do in the pre-hospital setting. All right. So any questions about those? And again, I kind of mentioned this a couple times, but it's not something that you're necessarily going to go, oh, well, I need to do this based on my protocol. But I'm sure that you guys have encountered situations where you get there and just simply did not know exactly what it was that the parent was talking about. And that puts us at a little bit of a disadvantage. But why I want to take this minute to kind of talk about that is when these kids get sent home from Children's Hospital or whatever facility they're coming from, the parents are trained, and oftentimes they actually have to go through testing and checklists before they will allow the baby to be discharged. So just keep an open mind. The parents are calling you because there is an issue that they're unsure of what to do with, and they can be our biggest asset. And my recommendation would be allow the parent to go with you as long as they're not totally freaking out. And most of the time they won't be. It's going to be, they're very calm. They just know that there's a problem and they need to get them back to the hospital so that they can be evaluated. So try to give them the compassion that they need, treat them with respect because they know a lot more about this particular situation than what we do.